below one, yeah, this bottom one, see, this is the tumor, yeah, and this is fused image, so we see the tumor itself, and it's uptaking, yeah, this FDG stuff in high degree. And this is, yeah, remember what we named special 3D reconstruction, which is maximum intensity projection, which is like summary picture, yeah, for PET study. And what do you see on this picture? Like normal distribution and this tumor, and no more, no more, no metastasis, no metastasis. What does it mean? That means that this is localized tumor, and we can use surgery, we can use radiotherapy on the first place, yeah, and that will be logical and practical. But if you look at that picture, this is the same tumor, yeah, you see the tumor, and it's again uptaking, yeah, this FDG thing in big degree. It's even cavitating, yeah, it looks like it's cavitating, yeah. And if you look at that picture, again, this summary idea of tumor burden in this situation, what do they see? Not only this tumor, yeah, but here and there, in there, and there. And so all these tissues, they are metastasis, yeah, they are metastasis. And that is that we can say that this is not a localized tumor. This is kind of grade 4, yeah, the stage 4 tumor, and that means that we should not start with operation or radiotherapy. They should start with chemo or targeted therapy because, yeah, the situation is generalized. And this is how it works. That's why it's important to have it in this clinical guidance stuff, yeah. Well, and let's pay attention, yeah, that we like two kind of pictures in this situation for different purposes, yeah. So we like slices because they can show us details where the metastases are situated, yeah. And so if we compare CT, PET, and this fused image, we can figure out where exactly each hotspot belongs to, yeah. But if we are looking for the amount to tumor burden, yeah, or how many tumor cells are in the body, this kind of picture is better, yeah, because we have the whole body at the same picture, and we can have the whole picture at one moment. People say that we can find lesions, tumor lesions from 8 millimeters, and this is kind of small size for a tumor to be recognized, yeah, so pay this attention. Well, to continue, let's see that there is another useful thing for FDG in tumors. These are follow-up studies. And this can be studies which we are performing in following up treatment. Yeah? So, for example, yeah, this is esophagus cancer, and it's avid to FDG in high degree. And this is the same cancer after treatment, 6 months after treatment. And we still see some tumor, some volume, yeah, but it's not uptaken FDG. It's uptaken, it's the same level like myocardium or liver, that is not high uptake. And that means that this is a good job, yeah, because, yeah, still some tissues left, but it's not accumulating, so it's not active, yeah. So this is very important. We can differ, yeah, from remnants and still living tumor, yeah, so this is living tumor, yeah, so this is important. Another good example, yeah, lung cancer, yeah, and this lung cancer is, yeah, at the beginning, 4 months and 14 months after combined chemo and radio treatment. And what do they see? Yeah, step by step, first it's smaller in size, yeah, and less in uptake. And at the last picture, it's small in size with new structure because they see a cyst, yeah, and fibrous tissue and no uptake. That again means, yeah, they still have some remnants, yeah, here, and that's okay with tumors, especially after severe treatment. They still have some volume, some tissue, but this tissue doesn't have live tumor cells, yeah, and so that means we can stop this severe treatment, yeah. So that's why it looks so good in this situation. And again, this is a patient with multiple myeloma. And this is the beginning of the disease, yeah, at the presenting of the disease. This is 4 months after chemotherapy, and this is next 4 months after chemotherapy. And so what do they see there? Yeah, first of all, it was a disease, yeah, and it was widespread disease at the beginning. And when there is a hope that we'll manage, because on these pictures we see like that situation is better, yeah. They see less lesions and they are taken in less degree. But unfortunately, 4 months later, it appeared to be a failure
Again.
because we have even more lesions than on the initial staging picture, and we even have specific tumor in the heart of the patient, and this is kind of really bad prognostic sign. Yeah, so this is how it can work. And what is also very nice, yeah, that we can follow up the patients which we thought to be cured from cancer. And what do they do usually? Yeah, they are screening them once a year just in case. Yeah. So this is a patient with thymoma. How do you pronounce? Thymoma.
Fibroma. No, fibroma.
Not fibroma. I mean this gland thymus.
Thymus.
Thymus. And how we pronounce thymoma or thymoma. Okay. So this is a patient with thymoma, and actually everything seems to be good. The treatment was completed, and there were 5 years of what we name of survival without any signs of the disease. And 5 years later, at the next screening study, and this is good screening technique, yeah, because we can have information about the body from one study. And what appeared, yeah, we found something, yeah. So this is, yeah, a new lesion, and it appeared to be metastasis. But since we were on check, yeah, on the right time, yeah, it was treated with radiotherapy, and the situations again was good, yeah. And it's easy way, yeah, to look for relapse or progression, yeah, after treatment, yeah. So this is also very important and useful, yeah. Pay attention to this. But that is not the only thing which can be studied with FDG. So this is the most important, the most widespread, the most used. But you see, using FDG, we can assess the amount of working brain, because yeah, brain likes sugar, yeah. And so this is the brain of a healthy person. This is the brain of an old person with mild cognitive impairment, something mild cognitive decline. And this is the brain of the patient with Alzheimer's disease.
Alzheimer.
Yeah? And you see?
Alzheimer.
Actually, the word is Alzheimer because it's a German word, it's a Swiss word. And it's a German thing. But anyway, yeah, at the origin it was Alzheimer because it's a Swedish, Swiss last name. Yeah. Okay, and you see the difference. So this is working brain,
this
is brain of the patient with dementia, severe dementia. Yeah, and this is big difference. Yeah. And what else can be done in patients with ischemic cardiac disease? This is also kind of really interesting application for this FDG stuff. For example, usually, we mostly use R&D in these patients for looking at perfusion and to finding ischemia. And usually, if we use these radiopharmaceuticals, we look here. This is slices, from heart study. So this is axle, and these are 2 longitudinal studies. And the heart is supposed to be like kind of horseshoe, and both part of this horseshoe, they should uptake this, And in this patient, they see that only 1/2 of this horseshoe is uptaken, and this is what we'll name cold spot, cold area, and this is the area of ischemia, So that's why, we can use it for studying this disease. But you see, if this patient with ischemia has the picture with FDG like this, so what's the difference? On these pictures, on this area which is cold, we see uptake. So this part of myocardium is still eating sugar. It's still alive. It's just hibernating. So that means, in treating this patient, we can use active modes of treatment, for example, stent placement, And after that, there are hopes that this myocardium will revive and work again like new, or almost like new, But in another patient, we see something like this, No perfusion, just 1/2 of the horseshoe, and no sugar uptaken. What does it mean? That they are both bad. We say match. This picture and this picture, they show the same picture. What does it mean? That this myocardium is not hibernated. It's not working at all. It's kind of dead. Probably this fibrous tissue there, that doesn't like sugar. And what does it mean? That there is no sense of trying placing a stent there, yeah, because there is nothing to revive. Yeah, and so this is how we can use this interesting idea, in diagnostics, these people. Yeah, and pay attention that this is kind of really popular idea in R&D to make what we name pair studies. What is pair studies? That means, that we use two different radiopharmaceuticals which we produce different information about different aspects of functioning, and then they're comparing them. And we are making conclusions from this comparison, like in this situation, yeah? So this is what the name paired study. This is not the only one. And there is one more thing which can do really cool using this FDG thing. We can look for specific inflammations. Let's say inflammation. What can be specific? The clinic can be specific, the spreadment can be specific, and the position, the location could be specific. Yeah, it's a really good idea to use it for looking for inflammations close, for example, to metallic medical implants. Yeah, we are using them a lot right now, and they can be a source of really severe, really really bad infection. Yeah, sometimes mycotic infections or mycotic. I don't know how to pronounce it. Yeah, and so mycotic. Yeah, and so that's how it works. Yeah, so in this situation, this area could be the area of big eating sugar. Yeah, so the high metabolism, and we can figure out it. Like in this patient has a big aortic aneurysm, and it was stented. Yeah, we place a stent there, and this stent is all infected with this mycotic infection, and so that is kind of really practical way to look for this infection, because close to the metal we have problem with performing all our diagnostic modalities. CT and ultrasound and MRI, they don't like metal, and it's kind of really difficult to see something in detail close to this thing. So this is a solution in this situation. And this is a boy, which has what we name like fever of unknown origin. Do you know this thing? Fever of unknown origin. This is a situation, very complicated clinical situation, where we have to think about many disease, and then there is no kind of local disease. It's kind of really impossible to figure out what's happening. And so in this situation, FDG is really useful in two ways. It can help us to exclude tumor and inflammation. And in this boy, it appeared to be Crohn's disease, because all its intestines, they are active, and that's the inflammation in this thing, and so it appeared to find this. And the last thing which we'll discuss with you, this is that there are positive and negative approaches in R&D, and let's look at them, following these familiar pictures. So this is the picture, of FDG study in patients with, let's be Alzheimer's disease.